Okay, you can hear me okay, Diego?
Yeah, we can hear you.
Okay, everyone, it's a pleasure to meet you, and I look forward to giving you a short presentation on some aspects associated with 3D printing and innovation in healthcare as we do in the Rapid Innovation Unit at the University of Limerick. I'm the director of the Rapid Innovation Unit, and ultimately our innovation group that I lead are at the interface between the university and also our local healthcare system. Over many years, we were involved in medical device design innovation, but this is somewhat different because this is looking at how we can have innovation skills in healthcare. So we have two primary aims in the Rapid Innovation Unit. The first one is to help develop, so ultimately engage and empower frontline staff with innovation skills. That goes from everyone from the porter to the professor of surgery, and the whole idea being that people create a fundamental skill set of being able to critique and question the way things are done on the basis that maybe they can be done better. And sometimes that doesn't necessarily even require a big innovation, but it's a critical thinking that's really important. And sometimes you can simply buy something off the shelf that helps address that need. But so we're really interested in innovation and critical thinking around the way things are done in healthcare with our staff. So the first thing is working with them to develop a critical thinking skill set in innovation. Sometimes when we say this, people think that we're going to train people how to design the next prosthetic heart valve. That's not necessarily the case. It's far more fundamental than that. In parallel with that, we also provide a service to help develop the actual innovations and implementing things and designing solutions. This all feeds into creating a supportive ecosystem. So the ecosystem is having designers available. And quite often when we interface with groups, I suppose the initial thinking on their side is that we're going to help try and solve a problem. And it is. But actually in going through that process, they are inherently going through a design process, maybe for the first time, scoping out a problem, looking at a journey map of the patient in a service. And in the course of getting to either a prototype solution or maybe an implemented solution, the staff themselves are going through an educational process around innovation. And if at the end it's brought, sometimes a solution will be brought to a research concept maybe, or a what if scenario. And in other times it'll actually be implemented. So we're going to show you some examples of some of these type projects. Very briefly to mention that we're mainly focused on the Midwest region of Ireland, and actually a number of the other hospital groups around Ireland have also their own variants of innovation groups. For example, St. James's, the Children's Hospital, Tala, the Mater, they each have their own innovation kind of groups. And we all operate somewhat differently, but we're plugged into each other as well, and we share experiences. I suppose we're actually focused on the Midwest because that's where we're based. But saying that, we share our experiences and we also learn from the other groups within Ireland and indeed internationally as well, and where we share our findings. So hey, we'll just very briefly, we'll work across many of the hospital groups, but very importantly, we have a specific strategy where we're also focusing a lot on the community, where we have a lot of people who are living with long-term disabilities, where solutions aren't currently available that adequately meet their needs. In terms of a design process, there's many design processes available, but I suppose in spirit we follow the IDEO design thinking process, and those of you who would have been through design training or maybe design school or university will be familiar with some of these. But in a nutshell, this is the type of process that we follow. The start of it is trying to understand the problem and then doing research on that. Of course, a very backdrop to all of this from an ergonomics context is user-centered design, and in particular, how we can try and identify where there's either not a current solution available or the solutions that are available are not adequately suitable for patients. Now, sometimes this can be a ubiquitous problem because quite often in healthcare, the way our current systems are and the products that are available are often that way because they've been that way for the last 20, 30 years. For example, Foley catheters are around quite a while, and they're actually quite good at what they do. But my point is that quite often we have things in our healthcare system and processes, and they've been that way because they've always been that way, or they've been inherited from other systems. So we need to be able to question as they evolve, is there an opportunity to do things differently? So that's where there's more of a ubiquitous type problem. Another variant then is where there's unusual patient needs that are really quite rare maybe, or don't happen very often. And because of that, they're just not commercially viable sometimes as solutions to solve. So hence the big medtech companies don't provide solutions. So anyway, we were interested in across these, the idea of how can we solve problems that are not adequately solved for our patient cohorts. This is a good example of something that's quite an unusual case. This is a gentleman, and now all the images I'm showing you here are ones that we've used and got permissions for either publication or for presentation purposes. So that's why we have them, and I'm able to show you. We have other ones clearly we can't if we didn't get permissions. Very briefly, this is a gentleman who went to Croom Orthopedic Hospital. Just to mention from the outset, this gentleman has no residual limb from his left, below the left elbow from birth. Ultimately, he was born with this, with no residual limb. Now, in the meantime, the gentleman had diabetes and he went to a hospital to have his right toe, big toe amputated because of vascular disease rising from diabetes. But in the course of the surgery, as can happen, it turns out the disease was a lot more prolific. So he ended up with just a below the knee amputation. So when the gentleman awoke, and no doubt he was advised there was a risk of this, he had no residual right limb. So he had no residual left limb and no residual right limb, a lower limb, I should say. The problem is for this gentleman, and he was 80 or 85, I think, he was actually reasonably active at this, but the problem is the traditional Irish crutch was no use for him because he had no left hand to be able to grasp it and mobilize. So what we did was we got an American style crutch. We 3D scanned his residual left limb and we made a rubber type socket here, as you see, attached to the American style crutch. Now, we provided this to him. He was in convalescence actually in Nina Hospital at the time. The OT staff reached out to us looking for a solution. And this is smack bang in the middle of COVID, I might say. And we provided this to him. He got up out of bed and tried it. And he was very demoralized, poor chap. And we didn't know what was going to happen. Sometimes with patients like this, they deteriorate, they take to bed as such, and they just never fully recover. And maybe, unfortunately might pass away with underlying illnesses if they're elderly. About 9 months later, I was contacted by the gentleman's, I think, granddaughter or daughter, and she sent me a video of him, and this is him on the right. He was actually now he wasn't going off walking kilometers a day, but he was actually mobilizing around the house, etc. And the video on the right shows him actually doing some of his therapy. So it turns out anyway, he was using, but the problem was he actually had wore out parts of it, and we had to tighten it up. So we were absolutely delighted for the gentleman because he was using it and he was somewhat mobile. The alternative is he was going to be limited to wheelchairs for the rest of his time. So there's a unique thing. We're using user-centered design with 3D printing and 3D scanning to help find a solution. Is there a commercial opportunity in this? No, there isn't. It's too a low frequency. This is another example. In this case, this is a lady who was in St. John's Hospital she actually had surgery. She had a stoma fitted for bowel cancer. This is a very well-witted lady, a very social lady. She loved to go out and have meals and socialize, an elderly lady. But while she was in the hospital, they noted she had very bad arthritis and she had a claw-like grip like this, and she couldn't really use her cutlery. So we took the designers took a photograph of her hand and ultimately made a device that you could slot in a traditional, fork or knife into. Now, it has to be said, there are solutions on the market for people with hand arthritis, but they tend to be tubular. And if you can't use those, well, you're going to have difficulty. And she couldn't. So they were down with her in the morning time, and by lunchtime they had brought up these 3D printed flat type devices, and she tucked into her lunch. She stopped. She had some yogurt with the yogurt spoon and tucked back into the rest of her lunch. So this is like from a user's perspective. If she doesn't have cutlery she can use herself, she had to be fed by someone else. So from a dignity point of view, I think we can relate to this. The same lady, we also noted she had a stoma bag, but she struggled because of the adhesive that she put it on herself. So one of the types bags, the Convatec bag, actually has a little pocket in the back, actually. So we just made a device that she could help put it on. We're not saying she put it on herself all the time, but she has some degree of independence to be able to at least try and put it on herself. So I think we can relate to the dignity importance there. Next is another example of a case of a highly rare condition. Thankfully, it's very rare because it's a really horrible disease. This relates to a young gentleman who was in Milford Hospice in Limerick with a form of cancer called rhabdomyosarcoma, which is a very aggressive form of head and neck cancer and typically targets pediatric populations. The prevalence, I think, is about 1 in 3 million when it occurs. So it's highly rare. In this case, the cancer tumor had targeted in behind the left eye of the patient, young gentleman, and ultimately the nurses, now he had perception of light in the eye, but he had no vision. And the nurses were struggling to put an eye cap over it to keep the air off the eye because it was protruded out and was permanently open. They were trying to keep the eye moist, and they were also trying to seal it from the air and to also obscure the light so he could have some degree of comfort and sleep where he could. Now, this gentleman was terminally ill. And the current eye caps were, because the eye was protruding, the eye caps were touching off the eye, so that's not a runner. And the nurses were taping loads of stuff around, etc. So the solution was we 3D scanned the gentleman's face so we could print a model of the eye. We made a bespoke cover around the eye and then got a lead from a light torch for your head and put it around. So there was a bespoke covering for that. Now, the gentleman passed away, unfortunately, a number of weeks later because of the terminal condition that he had. But we were advised by his parents that ultimately it provided some degree of, I suppose, assistance to him in his final weeks. We're not saying this fundamentally changed the gentleman's life in any way, but he was less conscious. He was very conscious when his family were coming in to visit because of the way of his appearance. So if it helped in 0.5%, it was worth doing. Now, this is a paper that we published, if I go back the slide, in a treaty in a BMJ supportive and palliative care. And what's important here is that a number of months later, we were contacted from a parent over in Pennsylvania who had a similar type situation. And I suppose it goes to show the importance of publishing results. And some of these we actually published. This is a case report. So they're relatively straightforward to publish, and an N equals to 1. But we need to be able to spread the word so that other people can learn from it and their local groups maybe help them, etc. Okay, this is something is quite different in the sense that this is a highly frequent thing that occurs, an injury called mallet injury. And it occurs to the tip of the finger. In America, it happens because of baseball, where you get a strike injury. In Ireland, it happens a lot because of hurling. And other sports are injuries where you ultimately rupture a tip of the finger of your injury, your tip of your finger here, a tendon. If you don't splint it correctly and hold it right for a number of weeks, you end up with a bent finger for the rest of your life unless you get surgery. So for some people, we have those aluminium splints, or else there's a thing called a stack splint. Now, they're like shoes. They come in different sizes. Sometimes they fit well and sometimes they don't. But if they don't fit well, then you can end up with this deformed finger injury. We were interested in how we could use ultimately be personalized healthcare here in the sense of having a data-driven model where the nurse can take 8 measurements. It automatically updates the digital model. You see it here, 3D printed, and you can see it. So this is a form of ultimately personalized medicine for an orthopedic condition. And we've done a clinical study on this actually, and we published results, and we had very favorable results. Now, we specifically, if I'm not mistaken, I'm not going to overstate things, but my understanding is this might be one of the first 3D printing of medical devices type studies in Ireland, but I'll stand corrected on that. When we were embarking on this, we wanted ultimately to pick an injury that's actually safe, and ultimately one that's, as I say, safe to do. And we were also interested in the whole idea of the personalization, the medical device side, 3D printing, and also healthcare professionals' impressions and perceptions of 3D printing. So it was part of the PhD thesis of Una Cronin, which he successfully defended recently, actually. And we published that actually in this journal, International Journal of Bioprinting, which is actually a top-tier journal, once again spreading the word of that. Next is an extension of that, where we were looking at how we can use 3D printing in healthcare, in this case dealing with diabetic foot ulcers. Now, going back to the gentleman with the crutch, ultimately, if diabetic foot ulcers are not adequately treated, then if an infection sets in, then the person may have to have their leg or foot amputated. That's pretty darn serious stuff. Ulcers in healthcare are pretty darn serious things. Ultimately, the problem we have is, this gentleman anyway ultimately got an ulcer. The procedure is an example, right? The procedure is you come in weekly into the health clinic, and what they do is they have this type of a cast where they try to relieve the pressure, and they have to take off an amount of the cast, completely take it off, inspect the ulcer, if it's okay or otherwise, and then put it back on. It's really time consuming. It can mean then that you can go long periods without being able to inspect the ulcer periodically. We were interested in how 3D printing could be used. Now, this is far more on the research side, And certainly we wouldn't be able to, we didn't do any direct clinical studies on this because it would verge into the higher risk because of potential leading into ulcers itself. So it is a lower TRL type project. We were interested in how we could have a bespoke, ultimately boot that you could more easily take off the bracing parts for inspection or otherwise, and being able to control the pressure relief. So, but that is more of a research level project. We'll move on to next, a very interesting human factors project from a patient perspective. And it deals fundamentally with communication in hospitals. And ultimately, there's a large cohort of patients who are in hospital who have struggles with communication. In our healthcare system, we have the traditional call bell, you know, the one where you press the button on it beside your bed and you can call the nurse. That's all well and good if you have enough dexterity to press the button. But fundamentally, there's a lot of people who have either poor dexterity or they're paralyzed and they don't have any way of being able to press a button. The backdrop to this was a case involving a gentleman who had a traumatic injury, spinal injury, after a car accident. They were, one night, they had very limited movement. I think they had movement in their right foot. All they could do was move the left foot, something like that. They were verbal, but the only bodily movement they had was their left foot like that. Either way, this gentleman almost choked on his own vomit in the course of the night because he was in a room and he vomited, but the nurses had no way, or he had no way of communicating to the nurses that he had vomited or otherwise and wasn't able to clear his airway. Now, thankfully, he survived that. But that was a real wake-up call, if I could use that term, that there was a significant problem here. So they asked us if we could help them. So we did. And what our designers did, they created, there's some 3D printed, but other mechanisms ultimately used, where we took an existing call bell, took it apart, and put the electronics into another switch-type mechanism, whereby the gentleman could ultimately turn his foot to activate the switch and hence be able to notify the nursing staff, for example. We thought, well, thankfully we were able to help him. He has some fundamentally far more difficult clinical things to deal with there forward. But next thing, there was a number of other requests like this over the coming weeks and months. Long story short, that the staff in the hospital eventually, they actually did an audit, the OT staff, they did an audit, and I think there's in the region of, let's just say there's 500 beds in the hospital, I should know the precise number. In the region of 16% of the patients in University Hospital Limerick were deemed to require a device like this by way of either being in full-time disability. And sometimes they'll often have what's called a special. A special is a one-on-one healthcare assistant or person with the person for situations like this. So there was more people then who would benefit, but ultimately there was many people who would require this. So initially we thought this is a very rare thing we want to be dealing with. Anyway, moving on from that, we had a number of other variants. And of course, depending on how the nature is, some people could just move their head, for example, maybe, or move their hand or something like that. So we had adaptations of this. Now, with the benefit of time, we eventually came across, now actually the challenge we had then was the hospital was looking for loads of these, but so we were getting them made in small volumes. Eventually, we came across a supplier for the paddle type part of this from America, you see in the top right. And the idea being that it's a switch. So we can now actually adapt this manufactured type switch to any kind of an articulated arm. And from a regulatory perspective, then it's far more compliant. Interestingly, and this probably won't surprise us, in our healthcare system, and take Limerick as an example, there's 4 different types of plugs for our call bells in the system. In one of the hospitals, there's 3 different types. Anyway, thankfully, different adapters can get over that part of it, and it's not a fundamental problem. But bringing it back to a patient level, the idea of being able to have communication for our patients is obviously crucially important for comfort and for safety requirements, especially those who have had traumatic injuries. Next is an example of this is an orthopedic example. This was a gentleman, as you can see, a strong guy from the photo. He worked in construction. He had a fall and ultimately fell on his elbow and had a traumatic elbow injury. And the treating surgeon linked up to us and said, this gentleman is going to need a different type brace than we normally can. First of all, he said, he has to have the hand pronated, and he ideally needs a small amount of elbow movement in his rehabilitation in order that he's going to be able to regain his recovery. Now, our first response to anything like this is, what's commercially available? Go and use it. And we insisted, the guy came in, no, he said, you're not listening to me. He said, there isn't anything available because this is a specific elbow injury that's highly uncommon, if I could use that, uncommon, right? And the current devices don't suit it. So what anyway, our designers did, we eventually said, okay, we've also tested, you're right, there isn't something available. So we scanned the arm and made a bespoke brace. And so it pronates the arm and in this position. But furthermore, it has a mechanism to have controllable articulation at the elbow joint, which is very important to support the rehabilitation of the elbow for this injury type. So here you see an example of that in place. Now, that was highly successful. And ultimately what the surgeon said is, if this chap doesn't have the correct level of therapy and support, he's not going to return to working as a labourer on construction. He said he's going to have fundamentally reduced range of motion of his elbow. Now, the gentleman actually, we did a follow-up, a one-year follow-up. He had regained 85% of his range of motion, and we published that as a case report as well. Now, we haven't come across many of those requests since, because the other injuries, he had what's called I think it's called a terrible triad elbow injury. That's the official clinical definition, a terrible triad elbow injury. And thankfully, that doesn't happen very often. Once again, highly rare, but hopefully we had that. Coming around then to another situation that we've had in the hospital, which is a very fundamental human factors one, is around medicines, and especially medicines that are used, for example, in emergency situations like anaphylaxis kits. And all operating theatres have to have these in case of emergency response. So what happens typically in our local healthcare system anyways, there's a box in the theatre. And ultimately the medicines are put into it to be used in the case of an emergency, of an anaphylaxis reaction. But what happens is, when there's a new medication prescribed, someone comes along and puts a new medication into the box and doesn't take out the old one. So with the passage of time, you end up with several medications in the box. And of course, in an emergency response, you shouldn't be trying to deal with this. Otherwise, you have to rely on having exceptional skills. So these are different examples of the kits. So having worked with the kit, and this is really a quality improvement type scenario, what we've done a number of variants of these for different similar type situations, where we've ultimately created specific boxes where the only thing that goes into the box is the required medication, and we use good labeling, etc., and have a protocol for taking out any previous things. We have some variants of this where the only things that will fit in, because we use inserts, etc., is the latest updated version. It's amazing how many when we present this as sample projects to clinicians, they say, oh, I need one of those or something else. And you're going, oh my God, how, so it's a classical human factors issue. And especially for something that is used rarely, but is used in an emergency situation, it needs to be right. Okay, I have just a few slides to go, and I'm going to show you another example of a situation in healthcare where there's a deficiency in the current solutions. This relates to work we're doing in relation to breast prosthesis for post-mastectomy patients who've had breast cancer. And I suppose ultimately through our engagement in the hospital, and the general kind of point being, is there problems that aren't being adequately addressed? And one of those that was brought to our attention was from the breast surgery unit. In particular, patients who have large breast size, who've had a mastectomy, these patients are either to get a surgical implant, but that's not suitable for everyone. So about half the patients probably have a surgical implant. Others will have a breast prosthesis, which is typically made from silicone. Visually, they're reasonably good and the color is good, but the problem is silicone is a dense and heavy material. So it's particularly a problem for people who have a large prosthesis or a large breast that's been resected. So the problem is the weight. What happens is, there was one particular client that was at the fore of this, and she had I think a size F cup breast, and she said, I really hate that prosthesis. It's really heavy, it's really uncomfortable, etc. And she really only wore it where she really had to, right? In all fairness, these patients are being through surgery, and it has the effects of reducing their perceived femininity, etc. So this brought us to the point, is there a better solution that we can have for these patients? Now, an interesting side thing that we've also learned along the way is that we might think that the patients, in terms of the actual weight of prosthesis, that the logical thing is to think, well, if you're able to calculate the weight of the resected breast, that the prosthesis should equal it. That's not the case. Our research has highlighted the patients want a lighter actual prosthesis. somewhat lighter because it's not surgically attached to their body anymore, and they want it for various comfort reasons. Anyway, our approach here was on a couple of fronts. And another thing as well is breast prosthesis are like shoes again. They come in different sizes. You might have one that's a reasonably good fit, or if not, you just have to figure out which one you're most comfortable with. That's not good enough for these patients really in this day and age. And as well as that, it's a standard one that is to cover left or right-sided use, which means it's not a perfect form for the breast that was resected or a perfect symmetry for the residual breast. So with this work, what we did was, there was two things. First of all, we focused initially on unilateral breast surgery patients. So we're able to scan the breast in the bra as currently for the residual breast and create a model of it essentially. And we also then took a scan of the residual chest wall post-surgery. We mirrored the model of the residual breast, and married it to the back surface of the chest wall. The chest wall is going to vary for everyone because the surgical site varies. What it meant then is we could create a bespoke breast. Now, these are not the latest images, but you get the idea of it. We're able to have a new breast prosthesis, which is a like for like of the residual breast, and the back wall surface of it, as you see here, is a resemblance of the actual person's negative of their actual chest wall. We married together. Now, we were able to then use, the next question was to use 3D printing to have soft-like materials where we could tune the weight of it to the weight that the patient wanted. The two things they wanted was a certain level of softness and a certain level of weight, and it is then a bespoke solution for them. So this is work which we've been advancing with our local clinical unit with some support as well from the Public Sector Innovation Fund with some other sources. And that brings me close to the end of my presentation. I will very briefly mention another project we have done as well with, once again, this was a lady who had a bilateral hand amputation because of another complex medical situation. The device is currently available for her, and she was actually a relatively active lady and a very positive-minded lady in her early 40s or 50s, I think. So we were engaged in another project with her, and she's also going through the National Rehabilitation Services. The final example here, and it's not unusual in the community of people with a lot of disabilities, with motor neuron type diseases and other disabilities, and they have a lot of communication difficulties using standard things to communicate. And one thing, so we've been working with them for quite often simple aids that help them to actually be able to do things like adjust their chair or their bed or communication aids for them. That brings me to the end of my presentation. Thank you.